Great, welcome back to the House Healthcare Committee. We are switching gears to the Department of Mental Health, and Commissioner Hawes is asked to provide some testimony on the Brattleboro retreat, and it's just part of our ongoing conversation around the Department of Health needs in our state. So I'm going to turn it right over to you.
Sure, thank you. Hello, Emily Hawes, Commissioner for the Department of Mental Health, and thanks for having me back again this afternoon. So we wanted to highlight a couple of points of clarification related to testimony last week. I'm also aware that Brattleboro Retreat has also provided a written testimony around some similar clarifications that we'd like to talk about today. So first, I'd like to highlight the work that we do in collaboration with the Brattleboro Retreat. Every day, the Department of Mental Health is working with their admissions team to triage appropriate folks or support the triage of appropriate folks into available beds across their units. And I also want to highlight the work that they have done in the last year to go from a 45 bed census about a year ago up to 85 beds, I believe, as of last week. And then you all heard about additional plans to get up to 100. Some points of clarification, though, from our lens circle around a couple of items, namely around the need for access to inpatient youth beds for folks who do have complex medical issues. So the retreat is accurate. They can serve many types of comorbid diagnoses. When we think about folks with complex medical needs, are those individuals who may have an eating disorder and have medical complications related to an eating disorder. Also those individuals who may be pregnant and have complications related to pregnancy. And an inpatient unit that is a part of an Institute of Mental Disease or a standalone hospital doesn't have your typical code team, so to speak, to respond to a medical emergency. And I talked about this a couple of weeks ago during testimony that in our adult system, adults have the ability to be admitted across the healthcare system in both units that are in standalone hospitals and then also integrated into our medical system. And that allows an adult who may have some medical complexities or nursing home level of care to receive inpatient psychiatry if they need it at a medical unit versus a standalone psychiatric hospital. So I wanted to take an opportunity to clarify what those differences are between a standalone psychiatric facility and one that is integrated into a medical facility. As an agency and a department, we are focused on diversification, and that's one of the questions is around how many voluntary folks are being admitted to the Brattleboro Retreat. So up here, this is a list of folks who are Medicaid. So this is only a slice of the picture of movement into the retreat. So these are youth who are both voluntary, so willing to go to the hospital, and also involuntary, so under the care and custody of the commissioner. When a voluntary adult needs inpatient hospitalization, they can choose which unit that they would like to receive treatment on. And triage will work to see if that unit has availability and, look to work with that facility for an admission if there's an appropriate bed available. For youth who are voluntary, their only option in state is the Brattleboro Retreat. They do have an option to go across the lake, like I said a couple of weeks ago, to Champlain Valley Physicians Hospital in Plattsburgh. They do have a youth inpatient unit, but we also wanted to have that opportunity to diversify here in state. So I think one of the questions that we fielded after testimony was around referrals. I think that there was a comment that they hadn't received any referrals in the past several weeks. And I think that was just perhaps a miscommunication internally there. So from our data to the retreat, and I'll focus on kids, although we have adult data in here. For the last week, 6 referrals have been made to the retreat, and 3 of those have been accepted. Now, the other 3 could still be pending, depending on if they need like additional lab work, or we're arranging for transportation, or they're refusing to go but don't meet EE criteria. So there are some complexities in that, but just to put this particular data point out in front of the committee.
Commissioner, are those individuals on the previous chart as well as these numbers, or are they the number of individuals non-duplicated, or are they incidents?
My guess is it's admission total, so there could be duplicates in there, but we can get clarification. The slide just before, let's say somebody could have needed a voluntary admission in July, was stabilized, discharged, and then also rescreened maybe a few months later, and that would be another admission.
But within the same month is what I especially wonder about.
There are some parameters around readmission dates within 30 days, and I believe it starts over. It doesn't continue. A new admission would be a new admission, but I can double check.
And so on the next slide that we were on, that again, this is Medicaid patients.
Medicaid patients, and so that's who we have the most data for. There are numerous youth accessing the retreat who are private. And those youth also also have the potential for medical complexities depending on their situation. We don't track or have access to that information. I believe that VAWS tracks that. We get involved if, say, a youth has been sitting for a while and has some complexities around the referral. Our care management team will work to break down any barriers if necessary to help facilitate an appropriate referral. One of the other questions that we received after or during testimony last week was around the number of folks who have been declined. So they've been referred and it's been declined. And you will notice since a leadership change, there have been no youth referred and refused. And so I want to highlight that positive progress that the facility has made. Now that doesn't mean that a referral was made and it wasn't an appropriate referral and so it was refused. These are individuals who were referred and met inpatient level criteria, fit into the unit, open beds. So you'll see that January, February, March of last year, that was happening pretty regularly. And then since April, there have not been any refusals is how we put that. We also provided information related to the adult system in this slide because we've also seen improvements around access to open beds from the adult system as well. There haven't been they've made great strides in their admission process in getting folks in who need to be there. And, you know, we talk about the different complexities in a referral, and I'll use, you know, maybe somebody at Central Vermont Medical Center may get referred to Brattleboro, may get referred upstairs to CVMC, may get referred to UVM and whoever has the first open bed, and where that person wants to go, they would go into that. Those numbers aren't reflected here because there are just some fast moving complexities related to that.
What is the difference between a general bed and a level 1 bed?
Sure. A level 1 bed is was originally a reimbursement term. And so what it means is a unit that's designed to allow for additional resources to serve somebody who may have a higher acuity. And so somebody who may have a higher acuity, maybe there's, you know, more options for one-to-one staff if needed. There's typically more psychiatric coverage in case an application for medication needs to be applied for. Those are all typically additional staff time to serve those folks. And so they get a higher reimbursement.
Great, thank you.
You're welcome.
Right?
Are level one beds usually secure units, or are there level one beds that are also not secure?
They're secure.
Would you, I don't know if everyone knows what that means, and I'm not the witness. Would you mind explaining it? Because I know what it means because I worked in one, but.
Sure.
Yeah.
So the Vermont has, many, I'm gonna say 57 level one beds, but that, I don't know if that's completely accurate. It's pretty close. So 26 level one beds at Brattleboro Retreat. 25, thank you, Nicole. 25 at Vermont Psychiatric Care Hospital, and I think 7 at the Rutland Regional South unit. Those are all locked units. Typically, folks in those units are folks who are under the care and custody of the commissioner, so involuntary. Folks also on those units could be somebody who has been ordered for competency or sanity evaluation related to charges through the court system. They could be somebody who's voluntary but require additional resources to be safely served at a hospital level of care. And it's all adults. That system does not exist for youth. And that was Vermont's approach to the decentralization of our state hospital system after Tropical Storm Irene. And so what you may hear is that after Tropical Storm Irene, the Vermont State Hospital, that bed count has never rebounded. But in all actuality, it has rebounded, and there are more beds than what the Vermont State Hospital had, which was 54 beds before Tropical Storm Irene.
Yeah, so I have some more questions. I don't expect you to answer today. I think if you have the answer, great. But I'm wondering if it might be possible, and it might be my computer's dead, so I can't turn it on right now, but so it might be coming up. But if we knew at each of these levels, the range of cost per bed, like if someone stays for a night, for example, if you're in the emergency room for a night, how much is that stay, the range of that stay? And if you're at level one, what's the range? At secure residential, what's the range? And then another thing that would be helpful is if you had any idea of how many beds are needed extra, or how many extra beds we have. Like, in other words, is there any level where we have too many beds? Is there any level, I'm assuming each of them probably doesn't have enough beds based on experience, but it could just be that they're not staffed beds. So just understanding a little bit of what the needs are in each level, because then we can better conceptualize like the need, the cost of meeting that need, and the current cost,
It does make sense.
Okay.
So there are inconsistent reimbursement rates across the system. I think you see that a lot in healthcare in general. And so I'll talk broadly because I don't know the specific daily rates. But say a hospital like Vermont Psychiatric Care Hospital only relies on those 25 beds to staff and administration, who has to follow the same CMS Joint Commission hospital licensing standards that any other hospital does. And so you typically see a standalone hospital have a higher rate because they're having to support those administrative services with only those bed stays. Where in a medical facility, you're seeing all sorts of different levels of billing, inpatient, emergency room, play into that administrative burden, so to speak. So you might see those bed stays be less expensive because it doesn't require the full support of an entire administration. There's more funding streams that are happening into that. The question about do we have too many beds or not enough beds, I'll reshape that a little bit. Because what we haven't been able to do is catch our community resources up to in a way that is providing sufficient community care to adequately project our beds. So we know we need diversification, we know we need more integration, but we also know that we have a community health system that hasn't necessarily been on par with the growth of hospital. And so we have a lack of, you'll see that we've made some progress in that in this last year, right? the alternatives to emergency departments, our mobile crisis. We do believe intervening with folks and supporting folks up here impacts the need for the highest levels of care, but we want those levels of care available if and when they need them.
I just appreciate that analysis that you can't predict the higher level care because we haven't properly invested in the community care. I appreciate that.
Art, and then we're gonna let.
Yeah, and what I'm gonna ask and say, it comes from ignorance in terms of just what the problem is, because we hear about kids waiting in emergency rooms.
Yeah.
We heard the other day from Brattleboro Retreat that they've got plenty of beds. I'm trying to get to the truth. How many beds are occupied in Brattleboro Retreat? You know, for kids?
Today, I don't know. I can find out.
Okay, and how many total beds do they have available to children?
Oh, to children, I think it is 30. And that's a mixture of youth beds from like age 5 to 12.
Okay.
Maybe 5 to 11 and then 12 to 18. And then we talked a little bit about some flexible beds that they have incorporated into an unused adult unit where they swing about 5 to 7. Sometimes they're filled with adults, sometimes they're filled with youth, depending on what the system needs.
Okay, so.
Those are getting ready to swing back over to adolescents. There was an increase in adult needs, I believe, and our retreat partners could better articulate that than I could.
Well, and stop right there. I don't understand, and it's nothing against anybody, but why can't you come in with them and sit in front of us and let's get this thing straightened out? I just am so confused. We hear one thing, we hear another thing, and I don't know what the truth is. You know, it would be just great to have everybody sit down and let's figure this thing out, including why we can't have people with kids with medical problems at the retreat. And you got a hospital right down the road.
Except for there's a difference in calling an ambulance to the retreat than calling an ambulance to a medical unit.
Okay.
The retreat does have some delays. They're going through locked doors to get to those. And if your kid's coding on one of those units, you're gonna want medical response in a quick and efficient manner. The retreat does take folks with medical issues. Somebody who has managed diabetes, that's somebody who's gonna be able to be adequately served there. So I think it's more looking at it a lens as what's the best care that we would want for our family members. You know, and I think beds shift throughout the day, right? So somebody could come in the morning, another person is discharged an hour later. And so that bed availability is flexible throughout the day, depending on what the needs are of the person in it.
Well, understand that we heard from them, and I know you probably know this, that there is no problem with that. So I sit here and go, what's the story?
So, and that's why we have the commissioner back in.
Right.
And that is also.
Everybody together, we can get to the bottom.
It is also why Brattleboro Retreat sent a letter, which everyone has received evidence on the committee page. And I think it's really important to also then look at the data that we're receiving from Roz on a weekly basis. And on January 19th, and so granted it's a week old, that's the latest one I could find, there are 5 youth waiting in hospitals. And 2 of them, 1 to 6 days, and 1 of them longer than 6 days. So on any given day, there's still a problem in our emergency rooms where youth are waiting.
Okay, I mean, we can, all right, whatever. I get it, but I just, when we hear from one group that it's not a problem because they've got plenty of beds, I sit here wondering. I'm not down at Brattleboro Retreat. I mean, maybe we ought to take a trip down and see what the heck it is.
And absolutely do a field trip to Brattleboro.
Cool, Montana.
I have a question about that. Is the issue, and I don't know who answers this, if you, maybe the commissioners are titled now, right? I'm trying to make sure I don't call people secretaries when they're. Maybe the commissioner could answer this, is like, if there are open beds at Brattleboro, but people waiting in an emergency room, one of the issues you brought up is that they can't go to Brattleboro because of complex medical needs. Are there other barriers for why those beds, in other words, like, what are the other barriers keeping people from accessing those beds and what are the beds they need?
So, somebody waiting for a bed who's voluntary, and I think I'll keep it at voluntaries because once somebody converts to involuntary, you lose the option,
That's
so to
different.
speak.
Yeah, I get
Your,
that.
your rights shift a little bit. But somebody could say, no, I don't want to go to Brattleboro. I'm going to stay right here until maybe a bed at Champlain Valley Physicians Hospital opens up. So that's one complexity that plays into somebody who may be waiting for multiple days. Somebody may be needing hospital level of care, but also may be able to be supported in a crisis bed if the crisis bed is staffed appropriately. And so a physician in an emergency room would be working with screeners to determine, does this youth really need to go to the hospital or do we have a community placement that could adequately serve them? And that might take a day or so to sort through. If somebody needs additional labs because, a blood work came back and something might be pointing more to a different medical issue, there may be a delay in placement related to that. Thank you, Nicole, for putting up the broader bed system. I got most of that right. Oh, yeah, that's a good reminder. Additional complexity is, which we've had this happen in the adult world too, is if two youth know each other and need referred to a unit, it sometimes cannot be a great mix on the unit to have two youth who may not necessarily get along to be there at the same time. So there's certainly some complexities there. Thank you for that reminder.
It's definitely not a linear process, right?
Right,
So it's
very-
not 5 people
Right.
waiting, 5 beds are open. Those 5 youth are going to go into those 5 beds because of some various reasons you've listed and probably others, which makes the whole situation extremely complicated.
It's very complicated and, we want folks we don't want these conversations to deter folks from reaching out and seeking support. And so we're very mindful about the narrative of not enough resources. We want to acknowledge that, but also want folks to know that they can reach out and that will get them services.
Joe?
The question I have is, I think one thing I've been trying to wrap my head around is like, where is that dividing line between a medical condition that you can go to a standard bed for, and then a medical condition that requires the higher level of bed that, if I'm understanding things correctly, and please correct me if I'm wrong, that we currently don't really have in Vermont.
I would leave that up to the treating physician and the admitting physician.
Okay.
So typically there would be a conversation between a treating physician, an admitting physician, to sort through the details of the case. And if if the risk for medical complexity was relatively low, then the likelihood of admission is higher. If both physicians feel like there is a risk for some other medical complication, then that's when, either more lab work needs to be done to really have a better understanding of that presentation, or a referral gets made to a different facility.
So it's not bright line, it's case by case.
It's gonna be case by
Great,
case,
thanks.
like everything.
Yes.
And I think that's important because then it's the person, they're determining that person's care, rather than trying to fit everyone into a box. Leslie?
If I could just add, in the context of what's going on in the unit. So it's not just this one person.
Correct.
It's a bigger system that needs to be thought through.
Commissioner, go ahead.
Quick one. Closed, what does that mean?
Sure, a closed bed can be that there's not enough staff to adequately staff it. It could be a double, I don't know if folks are having double rooms anymore. They might have made permanent shifts to single rooms, but maybe like somebody's, a room is a double room and somebody can't tolerate, another person admission into that bedroom. Acuity on the unit, perhaps there's folks who are really struggling with being on the unit and interacting with the other patients. It could be a whole host of things, unfortunately. But typically, these days, it's related to staffing.
So when you look at the first column where it says the number of bids that we have, you subtract all of the closed ones. Is that right?
Yeah, and that could change. That changes also during the day. It could be that a unit is experiencing call-outs. Either like several nurses call out or something like that. That could close a bed for a day, and then, come back online the next day. But yes, so you will see from the adult lens, 200 adult inpatient beds, 150 of those are filled in this snapshot. And 29 are closed for a variety of reasons, and that's all across the adult system.
And I think, because we've been focusing on youth inpatient here, I think what's telling in this snapshot is there were 30 beds, 17 occupied, 13 closed, and 0 open. So that is when you start getting the people waiting in the hospital and the emergency rooms potentially, because there's just not the open beds.
Yeah.
So Commissioner, we went off on a lot of different questions. I want to make sure you finish the testimony
I have, thank you.
Okay. Any other questions before we call it a day?
Are those bottom three, are they all in the Brattleboro retreat?
Can you restate your question? I'm sorry.
The bottom three up there?
Oh, youth inpatient, adult crisis beds, and youth crisis beds? No, the only beds at the retreat for youth are the youth inpatient. The youth crisis beds are community beds, like NFI in the Chittenden County area. Adult crisis beds are typically associated with our designated agency system.
So it just says a statement. If Brattleboro Retreat is the only place that the youth can go, and we heard some things the other day, 30 beds, 17 are occupied, 13 are closed. So to me, that says that almost half their beds are useless.
At this point in time.
In this snapshot.
Correct.
That, even if it's today, one day, that's a lot of beds.
It is. Right, which goes back to the Brattleboro Retreat testimony of 45 beds, I think it was this time last year, that were, only 45 were open. Now we're up to 85 that are open, which includes these youth beds, and we're trying to get to they're trying to get to the 100 and.
They are, with an increase on one of the, I believe, the adolescent units. So yes, that 45 last year included kids' beds, which I think topped out at around maybe 8 or 9 total at that point. So they certainly, made some significant progress in that.
Joe?
I was wondering, and I totally understand why Snapshot's so important to your work. I'm wondering, is it possible to get moving averages on some of this stuff, maybe over 3 months? Just because I know one thing, because it's possible, and again, we just don't know, that those 13 beds just happen to be a today thing because a couple nurses got sick or something like that. But really, it's typically only a couple, or it's possible that today's a good day, and really it's more than that. So it might be like 3-month moving averages. That'd be really interesting to me.
I can check, yeah.
Great, thank you.
It's been 13 for a number of days.
Okay.
I've seen that number.
So the closed bed, I'm sorry, it's a question. I follow Leslie. Now I'm forgetting what I'm doing. So the closed beds basically are because of staffing shortages?
Yeah, it's gonna be a mixture of staffing or acuity.
Okay.
Great, thank you, Commissioner. I think suffice to say, there's more work to be done, without a doubt, and we appreciate you coming back and helping us understand all of this.
Yes, thank you for having me. Appreciate it.
Thank you.
So I just want to talk a bit about tomorrow before we leave today. So tomorrow we are doing the field trip to the
July.
Yes, I want this to be on live.
Did we have to pick our thing?
No. So we are doing a field trip to the Washington County Mental Health Services. There is also, so the plan is we would be there from 10 until about 2:30, come back in time to be on the floor. There is also caucus of the whole on tomorrow at noon, which is when they're going to review the BAA. So there was a request that someone, at least someone wants to come back, which is fine. And, you can choose to come back and stay back or come, whatever you want to do. So just want to be clear that, and now I can't find my email, so hold on one second. I think that's during the lunchtime over there anyway.
Could we watch it remotely while we eat lunch?
I would say not as a group because Human Services will be there as well. And there may be people eating with us that don't want to partake. But if you wanted to bring your iPad and find another spot to watch it at, absolutely.
The place in Berlin?
Yes.
You just reminded me though that like when I miss testimony here, I watch, for the record, I watch it later at like 2 times or 3 times the speed, but I watch it. We could just watch it later. So
Absolutely.
I didn't even think of that. We could just watch it later.
I
Yeah.
had forgotten.
And you could watch it twice as fast and watch it in less time.
Yes. So the Washington County Mental Health Services
In Berlin,
in Berlin.
up by the hospital? I thought they closed that.
So what do we do, all drive over there?
Yeah, hold on. I'm sorry. I got distracted and I need to find the email that tells us what we're doing. So we can carpool. I'm happy to, I can fit 3 comfortably more. So we can talk the carpooling offline. What I want to be clear about is, obviously, if you want to come back and be in person for the BAA or any part of the day here, that is obviously okay. I would just say, let's make sure I know that before we go over. I can't find the email. We will be going over, so be there by 10. There'll be a group session where they're going an overview of what they do. And then we'll have lunch. And then there's different places we can choose to visit. We don't have to do that. Thank you. Phone a friend. No, I didn't get it yet.
Double email. Way down the list.
Didn't get it yet.
I can take 3 or 4. I got a truck.
Okay. Yeah, so we can talk that offline. So anyway, Joe, did you have anything else you wanted to talk about with
Just
that?
trying to confirm, is this, because I'm looking at the address, is this 286 Hospital Loop, Unit 9 in Berlin?
Yeah, we can do, let's do logistics off
Okay.
off air.
That's fine.
Let's just make sure we all know what, I just want to be clear that you can come back here and do the BAA and come back, stay, whatever your choice is your choice. Just let me know
It's a short drive.
once we're there, yes.
Whatever
How far
Milton-
is it?
Okay, so it's about 15, 20
It
minutes.
is 10 minutes from here, according to,
Okay.
So the other thing, I'm sorry,
Caucus of the whole is at noon?
caucus of the whole is at noon.
Gotcha.
Okay. Which also is going to be recorded. I did confirm that today. So then I also wanted to go back a bit to the compact. So there's quite a few letters of support online. So from local Vermont clinicians. So please check those out. We have a potential vote for Friday. We try to put it out there on the agenda so that for a couple of days, so that if people see what we're talking about and there's a potential vote, they may come forward with more input. So it could be, there's other counselors want to send us written testimony. So we just leave that time open, but also alert people to the fact that there is a potential vote coming up. Most likely the vote will be next Tuesday, which we will put on the agenda. If there are things you need to understand, or more importantly, witnesses you still feel we need to hear from, let's talk offline and we'll make sure we get that done before the vote. And we will have a committee discussion before the vote to answer questions before we actually take the vote.
I thought it was interesting that the people that wrote in were licensed social workers, which are not relevant. So I thought that was a bit of a confusion about what's going out and, what people are learning about this.
Go ahead, Brian.
Yeah, I didn't get to watch all the testimony from earlier yet. I plan to do that tonight because I was in another meeting. But what I just heard you say, like what, you know, like the relevance of licensed clinical social workers supporting it, I think what that speaks to is the significance of the allied health professions, how like even though this compact may not help the social workers yet, as a social worker, I would say we recognize we need
The
more,
value.
all of us, yeah. And I have a short form bill that, I don't know if this is a good time to talk about it, but like, if anyone wants to sign on, I'm gonna hand it in today, that talks about joining all of the compacts as soon as possible. And I think that speaks to the issue of like, that there's mental health counselors and psychologists, but social workers are looking now at creating one. And there's other professions in the health field that have them. And at this point in history, I think it behooves us to look at every possible path. So I think that's just to say, like, I think that's the relevance of the social workers being on record, is the
Makes sense.
recognition that we're interdisciplinary and that
Yeah.
we're on the same team.
Good, thank you for that. Yeah, I hope that helps me. I was
Yeah.
afraid that they were thinking they were getting something they weren't. That was.
They might though, so we don't want to be clear.
Yeah.
Okay, so I think we can call it a day. Thank you. Long testimony.